ถามนิดนึงไฟล์ข้อสอบที่ผมส่งไปแล้วได้รับแล้วใช่ไหมครับ
ได้รับแล้วค่ะอาจารย์
โอเคลองไปเลือกดูนะกันนะอันนี้คือที่ผมออกไว้ตั้งแต่เมื่อสัก2 ปีก่อนละแต่แนวข้อสอบมันก็ยังเหมือนเดิมไม่น่าเปลี่ยนนะ
ได้ค่ะอาจารย์ขอบคุณค่ะ
โอเคขอบคุณครับ Hello everyone Are you ready
Ready อาจารย์
Everyone coming already Okay, let's start. Today, I will talk about the diastolic function evaluation. Okay. About this topic, I got the results from the 2 guidelines. It come from the ASE guideline 2016 and the European Heart Imaging. If you want to see the detail, you can pick up this paper and to read on the detail again. The main contents today, we will talk about the first one, the physiology of the diastolic function. Next one is the method and how to assess the diastolic function from the echocardiography and how to evaluate the LV filling pressure and grading of the diastolic dysfunction and some special conditions, particularly the atrial fibrillation that is a common seen in the real practice. Okay, why we have to learn about the diastolic function? You know, in the United States of America, we see the patient who comes with the heart failure. Heart failure is divided in the systolic heart failure and the diastolic heart failure. In the diastolic heart failure, it's the common seen in the worldwide, including Thailand, in the United States. About 60%, 50 to 60%, the patient has a diastolic heart failure or heart failure preserved ejection fraction. About 40 to 50% is a systolic heart failure. It's the group of the systolic dysfunction. So in this group, sometimes we see this group is called heart failure with preserved EF, or sometimes we see in the heart failure with mildly reduced ejection fraction. That's a ejection fraction between 40 to 50% is called the mid-range or mildly reduced ejection fraction. Okay, the physiology of the diastole, basically the heart function is divided to the systolic and diastolic. The systolic, the systolic is divided into 2 phases. The first one is the volumetric contraction. That is during this phase, there is no flow from the LV to the systemic circulation, but this phase is generate the pressure without the flow. When it's generate the pressure, overcome the aortic pressure, so the aortic valve open. That start the second phase is the ejection period. That's the blood was pushed out from the LV to the systemic, pass through the aorta. Okay, this is the systolic phase. It's divided to IVCT, isovolumetric contraction time, and the second phase is ET, is the ejection time or ejection period. After finish the systolic phase, then coming into the diastolic phase. The diastole the main function is the filling the blood during the diastole. From the ECG, we look at the end of T wave to the initial of the next QRS complex. But the systolic phase is start from the QRS complex to the end of T wave. When the LV relaxation, the aortic valve and harmonic valve closure, but the mitral valve and tricuspid valve opening to flow the blood into the LV and RV. After that, atrial contraction to kick the last blood from the LA and RA to the RV and LV. This is the diastole. Okay, the physiology of diastole, as I just told it. Systole is start from systole is start from the initial QRS complex to the end of T wave. This is the systole, and the diastole is start from the T wave to the next QRS complex. So the diastole is take a time about 2/3, but the systole is take the time about 1/3 of the all cardiac, one cardiac cycle. Okay, the physiology of the diastole is quite different from the systole. The diastole is divided into 4 phases. The first one is the IVRT, is the isovolumetric relaxation. IVRT, what's about the IVRT? IVRT, when after finish the systole, the mitral valve, the aortic valve and harmonic valve is closed. After that, the RV and LV is start the diastolic phase. Is the start relaxation without any filling the blood from the atrium. This phase is the IVRT. It's like the IVCT. It's just generate the pressure to the lower. Okay. Again, IVRT is start from the end of systole. It's relaxation to lower the pressure in the LV and RV. When the pressure is lower, the LA and RA pressure. After that, the mitral valve and tricuspid valve is open. When the mitral valve open, blood flow from the LA to the LV is called the second phase. Second phase is the early rapid filling. This one is the first phase. It's the IVRT. Relaxation without flow. When it's relaxation, the pressure is come down. When the pressure in the LV is lower than the LA pressure, so the mitral valve is open. Then start the second phase. Is the called E or early rapid filling. This phase is the most important in the diastole because most of the blood fill in this phase is the second phase, early rapid filling. After that, when the pressure is equalized between the LA and LV, it start the third phase. It's called the diastasis. Diastasis is mean the flow is stasis because the pressure in the LV and LA is equal. After the pressure between LA and LV is equal, the last phase is generated by the atrial contraction. When the atrial kick or atrial contraction, Okay. The last one is the atrial contraction to push the last bar in from LA to the LV. This is our physiology of the diastolic four phase. Again, first one, volumetric relaxation time. When the pressure in the LV lower the LA pressure, the mitral valve is opening. And then second phase, early rapid filling. This phase is the most important because this phase is the most, but during the diastole is filling in the LV in this phase. When the pressure between LA and LV is equal, it start the third phase is the diastasis. This phase is just a little bit of blood flow from the LA to LV. When the atrial kick or the atrial contraction is generated the post phase to push the last blood from LA to the LV. This is all of the physiology in the diastolic four phase. Okay, again, four phases of the diastolic. One, IVRT is start from at the T wave. IVRT, this phase is the relaxation without any flow from the LA to LV. When the pressure in the LV is lower than LA, the mitral valve opening. When the mitral valve opening, it starts the second phase is the early rapid filling. The blood, the most of blood is flew from the LA to LV in this phase. After the pressure is equal between LA and LV, it starts the diastasis. This phase is just a return flow, this phase. And then the last blood is pushed by the atrial kick or atrial contraction is the fourth phase. Okay, after atrial contraction completely, is end of the diastole. Okay. So the main things we learn about the diastole because we want to know about what about the LV filling pressure in the heart. Before in the era of before the echocardiography came, we evaluate the LV filling pressure by the insert the swan catheter into the heart to measure the LV filling pressure by this method. But the echo can use to evaluate the LV filling pressure. Basically, today we will learn about this. Okay, in this graph it shows the pressure between the LV and the LA pressure, and it shows about the four phases. First is the IVRT. You see this one. The IVRT, LV is the, you see, this is the LV pressure. During IVRT, it's relaxation to make the LV pressure coming down below the LA pressure. When it's below the LA pressure, the mitral valve opening. When the mitral valve opening, is the second phase is very rapid filling. Okay, it fill the butt. When it fill the when the LA pressure and the LV pressure is equalized. See this one. So this phase is called diastasis. And the last one is the atrial click. Atrial click is here. To push the last part from LA to the LV is the atrial systole. It's the atrial click you can see from the ECG. It's follow the P wave from the ECG. This one, IVRT, early rapid filling, diastasis, and the atrial click you see is follow the P wave to the next QRS complex. This is the atrial contraction. First one, IVRT. Second one, early rapid filling. Third one, diastasis. And fourth one, atrial contraction. Okay. Anybody has question? This is I think is very important because this is basic physiology. The diastole, you have to understand about the four phases of the diastole before we go to the how to evaluate by the echo. Anybody has question? Okay. The diastole is need two processes of the diastole. The first one is the active process. Active process is mean is the ability of the myocardial to relax. This one, the active process, is need the energy power from the cell. That's the is the ATP. ATP is was created or built by the mitochondria of the cell. When the patient has the coronary artery disease, is lack of the or inadequate blood supply to the heart from the coronary artery disease. So this active process is need the energy from the ATP. So when the blood supply is inadequate, this process is impaired, then the patient would have the diastolic dysfunction. About the passive process is no need the ATP or any energy. It's the compliance of the myocardial to feel adequately. The diastolic function or the compliance of myocardial is depend on the many factors. The first one is about the myocardial function. If the patient has something that's error or the wrong component in the LV, for example, for the patient with the cardiac amyloidosis, this is the amyloid protein to deposit in the myocardium. This one, the myocardial is stiff, is quite tough to relaxation. And the second one is about the pericardium. The pericardium is covered around the heart. When the pericardium has the problem or disease, this might impact about the diastolic function of the heart. About the active process, it's used 75% is used the SERCA2 and 25% is used sodium calcium exchanger. The passive process, as I talked, is the compliance of the heart to diastole. About the compliance and stiffness. From this one, the ratio of the compliance is depend on the volume and the pressure. Compliance is equal delta volume / by the delta pressure. if the myocardium has the good compliance is mean if the have a much change of volume without a much change of the pressure. This one means this the heart is good compliant. Good compliant is mean this one good compliant. This one increased very much without an increase very much in the pressure. So the compliance is very good. This means the heart can fill a lot of blood volume without significantly increase the pressure. So this one is a good compliance. In the other way, the stiffness is mean in the opposite side from the compliance. The compliance boosts stiffness is no, it means no stiffness. If the compliance is bad, it means this myocardium is quite stiffness. Stiffness is the delta pressure led by the delta volume. This means if the myocardium is stiffness, so it's if the change a little bit in volume, this can impact the pressure change a lot. So this one is myocardium is quite stiffness. In the healthy myocardium, the compliance should be good. So that means when the volume is increased, it's not impact much in the pressure change. So this is a good or healthy myocardium. This one is show the pressure volume relationship. In the y-axis is the LV pressure and the x-axis is the LV volume. Basically, you see, this one is during this one aortic valve is closed. During this phase, you see, the volume is not changed, but this one, the LV pressure is dropped. When the pressure is dropped below the LA pressure, the mitral valve is open. So this phase is the IVRT, is the isovolumetric relaxation time. When the mitral valve open, okay, this phase is the second phase. It's the early rapid filling. You see, the volume change because the volume is filled from the LA to the LV. This is the early rapid filling is the second phase. When the systolic and the diastolic is okay. When this phase, the mitral valve close. When the mitral valve close, the LV is trying to generate the pressure. It's trying to generate pressure. This phase no flow, but the pressure is generated to overcome the aortic valve pressure. So this phase is the IVCT. This one is the systolic, and this one is the diastolic. When this LV is generated, the pressure overcomes the aortic valve pressure. Then the aortic valve is open. Then the flow is pushed from the LV to the LA. When the pressure between the LV and AO is equal, aortic valve closed. So this is a complete one cardiac cycle. Systolic, diastolic, systolic, and diastolic. This is one cardiac cycle. Okay. We go to the method how to evaluate the diastolic function. Any question before I will take a deep dive into the diastolic function?
ไม่มีค่ะ
มีใครมีคำถามอะไรไหมครับ หรือว่าให้พูดภาษาไทยดีกว่า
ยังไม่มีคำถามค่ะ
จะให้พูดเป็นภาษาไทยไหมครับ หรือว่ายังไงเดีย
พูด
ผม
เป็นภาษา
ว่าพูดอังกฤษแล้วมันจะรู้เรื่องไหมอ่ะ
อาจารย์ English is better
มีเพื่อนต่างชาติด้วย
Oh
ค่ะ
thank you Okay sometime in the hard point I will sometime we will change to explain in the Thai version would be better
โอเคค่ะ
Okay we start the method how to evaluate the diastolic function basically is from the simple 2D DM mode and the Doppler and the LA size and the LA function. You know, when the patient has the diastolic dysfunction, it means the LV is stiffness. So the diastolic function of the LV is impaired. When it's impaired, it's impact back to the LA. The LA pressure is higher. So after the LV relaxation or LV diastolic function is impaired for a long time, its impact to the LA will be enlarged in the long term after the LV diastolic dysfunction. So the LA is enlarged in the long term. Sometimes we call, the patient who have the diabetes, the DM, we look at the hemoglobin A1C for the patient with the diabetes. In this group, the patient who have the diastolic dysfunction, we look at the LA is the marker of the diastolic dysfunction. If the LA enlargement, which means the patient might have the long-term diastolic dysfunction. And there is one, the MPI or TE index is in the real practice is not commonly used because it's quite tough to measure a time change. So I will touch a bit about the TE index. Okay, general consideration before you to evaluate the diastolic function by any methods. You should pay attention in the clinical setting of the patient. Look at the heart rate, blood pressure, LV wall thickness. For example, in the patient who have the hypertrophic cardiomyopathy, or the patient who have the thick heart muscle from the long-standing high blood pressure or hypertension, the patient may have a LV wall thickness. Look at the LA size or LA volume. Look at the LV ejection fraction. The rhythm from the heart is the sinus or the atrial fibrillation. Or the patient who have the significant mitral valve disease. If you see all of these parameters, so I think basically I think if you see the abnormal or all this, I think the patient would have the diastolic dysfunction. From this one, it's very tough to apply all of this method to the children in the perioperative setting. Be careful to evaluate by the Doppler signals, and sometimes you should concern all of this one is is the load dependent, so it's depend on the heart rate and the volume status of the patient. So you should concern about this parameter before you evaluate the patient. So During early diastole, the factor that would impact the diastolic filling. The early is the preload, transmittal volume flow rate, and the atrial pressure. And the late diastole, is about the atrial click. So if the cardiac rhythm is changed from the sinus to the atrial fibrillation, so this impact the late diastole. About the 2D echo, you just basically look anatomical structure of the heart. I just talked to look at the LV wall thickness, LA is dilated or not. About the mitral valve disease, patient has the mitral valve disease or not. And the LA size or LA volume is the good predictor of the diastolic dysfunction. Okay. You see the echo, the picture is moving. Okay, in the left side and the right side of the patient, if you see which one is abnormal, between left and right.
left side ใช่ไหมครับ
Okay, left side, this one. Okay, this number 1 and number 2.
number 1 ค่ะ
If you guess which one would we have the diastolic dysfunction? Okay, you see.
I confused number 2 ค่ะ
Number 2, could you
Yes.
explain it? Why you select the number 2?
Because on the right side, it seems like the chamber is compressing and it's small.
Okay. So I think the only picture is not fair to you to give the answer. Okay, just give you more some clues. You see in the number 1, the heart contraction is okay. But when you see the number 2, you see this area. You see this one? That's I circle or mark it. What about this one? It's not contract in this area. You see? It's not contract. In this one, the patient is the Charcot-Subok cardiomyopathy. It look like the you know the Charcot-Subok. Okay, no problem. This one, if you see the patient has the LV systolic dysfunction or the patient suspect who have the coronary artery disease, this is a highly suspicious for the diastolic dysfunction. Okay, that's basically to evaluate the diastolic function, to look on the 2D echo, to see LV thickness or not, to look on the LV function, and to look on the LA volume index. In this picture, you see the patient have the thrombus in the LV apex. So the LV apex is show the thrombus. So this patient is likely to have the diastolic dysfunction and systolic dysfunction. Okay, this picture is quite important. You should know. Have you seen this before? in the part of the, I think, sir, have you learned the systolic function evaluation yet?
Yes.
Yes, okay. Have you seen this picture or this table before?
Yes.
Okay. Can you remember the number?
No.
No ค่ะ
Okay. To review it again, it is divided into the 4 category. The first one, you start with the LV mass index. To remember, in the female, the magic number is 95, and the 115 in the male. You have to remember this number first. If the number is less than 95 in female and less than 115 in male, this is a normal LV mass index. So the normal LV mass index is the normal geometry or the concentric remodeling. Concentric remodeling, you can separate by the relative wall thickness. The relative wall thickness, when you see in the echo report, RWT, you look at the RWT, it's the relative wall thickness. Relative wall thickness, you can calculate by the posterior wall thickness double and divided by the LV internal dimension during the artery. Have you measured it this one? เคยวัดไหมอะครับ เคยเลยลองตัดหรือวัดหรือยังเอ่ย
เคยคำนวณนิดหน่อยอะค่ะ
เอ่อ เดี๋ยวจะลองให้ดู Okay when you the cut point the M mode from the echo okay when you use the M mode to measure this one okay ECG is shown here. This is a ECG. When you use the M mode across the LV from the parasternal long axis or parasternal short axis at the mitral valve level, at the papillary muscle level, you got this picture and you measure it here during the diastole and systole. During the diastole, you calculate RWT, relative wall thickness. You measure this one and doubling of the two posterior wall thickness. Okay, measure this one, multiply by 2. Okay, and all of this number divided by the LV internal dimension during the diastole is this one. Okay, you will get the relative wall thickness. You got it?
yes ค่ะ
Okay. So in this figure, you start from the LV mass index 95 in female and 115 in male. Okay, if it's normal, maybe normal geometry or concentric remodeling, you use the RWT to separate between both. If the relative wall thickness is less than or equal to 0.42, 0.42 is the normal geometry. If this number is over 0.42, it's called the concentric remodeling. Why? You see, if the patient has the concentric remodeling, this ratio over 0.42, it means the thickness of the LV is increased, and then the LV internal dimension during the diastole is decreased. So that's why this ratio is over 0.42 is called the concentric remodeling. When the patient who have the long-standing high blood pressure before the LV wall is significant increased thickness, it starts from the concentric remodeling. When the patient is the uncontrolled high blood pressure for the long time, this will change from the concentric remodeling to the concentric hypertrophy. So the next one, when the patient who have the long-standing high blood pressure, it starts from the concentric remodeling. When the mass is increased in female over 95 and in male over 115, it means the hypertrophy. When the mass index is increased, it means the hypertrophy. Hypertrophy can divided to concentric or eccentric hypertrophy. It's due the relative wall thickness to separate between both. The concentric hypertrophy is mean increased mass and relative wall thickness is also increased. It's called the concentric hypertrophy. But if the mass is increased, it's called hypertrophy, but relative wall thickness is less than 0.42 is called the eccentric hypertrophy. In this group, we see the patient who has the systolic dysfunction. When the patient who has systolic dysfunction, this might have the eccentric hypertrophy because the LV mass is increased and also the LV side is dilated. When the LV side is dilated, the LV internal dimension during the diastole is increased. So this ratio is less than 0.42. Okay. Any question? This one is very important and sometimes I think I guess you can see in the examination. So you should, because this one is very important in the clinical practice, you should separate what's about the LV geometry of the patient. Is normal or is the concentric remodeling or concentric hypertrophy or eccentric hypertrophy? If the patient, the mass increase, so it's called hypertrophy. So the hypertrophy in this patient is concentric or eccentric. You look at the RWT. If the RWT is over this number, it's called the concentric. If less than this number, is called the eccentric. Okay? So the next one, how to assess the LA size or LA volume. The first one, you use the M mode from the parasternal long axis view. You put the M mode here. You measure the LA size from the M mode. Okay, and the next one is the standard to measure. The standard measure to evaluate the LA volume. We start from the apical 4-chamber view and apical 2-chamber views in this one and this one. You use the zoom mode in this area and measure the LA volume. You trace the area over here and in the 2 chambers over here. The machine is auto calculate the LA volume in the screen and in the report. Sometimes the LA volume is inaccurate in some special condition. For example, if the patient has something to compress from the external compression, so the LA volume might be not accurate to evaluate.เคยได้ลองวัด Have you measured the LA volume index? ได้เคยลองวัดกันบ้างหรือยังนะหรือว่าตอนนี้ lab close
ยังไม่เคยได้ลองทำ lab เลยค่ะ
Wow. So it's quite tough to got it. You see, you know this view, apical 4-chamber views. So if you sometimes you obtain the image is foreshortening, you might over the size of the LA volume. If you get the standard, this is you will get the other number of the LA volume. So I mean if you get the wrong picture of the apical 4-chamber view or the apical 2-chamber view, you might get the incorrect picture to trace the volume in the LA. So this is important. You should get the standard. You should obtain the standard apical 4-chamber and apical 2-chamber view to get the correct LA from the 4-chamber and 2-chamber to measure it and to make it correctly. This is a number you should remember. This one is the O. The last update from the JSE 2015. This number you should remember. Okay, normally the LA volume index. You see in the report is the LAVI or LA volume index. Normally it's between 16 to 34. If the number is over 34 is called the enlargement of the LA. It's separated in the three categories: mild, moderate, and severe. Mild, the number between 35 to 41, and moderately is the 42 to 48, and over 48 is called the severely dilated of the LA. You know, it's you just plus the in each length about the 6, okay, 35 to 41, 42 to 48, and over 48 is called severe dilated LA. This number you should remember. But the upper one, this is the old number from the old guideline, so no need to remember this one. This the new. But in the future, maybe this number might change again if we have the new data from the research. But the last update one, you use from the JSE is 2015. This number you should remember. Okay, the limitation of the LA volume measurement. Sometimes the LA dilatation is seen in the bradycardia condition. For example, the patient who have the sinus bradycardia or the high output state. Sometimes the LA dilatation you can see in the patient with the athlete heart or the well-trained athlete. This group might have LA dilatation. Sometimes I think so far we always seen the patient who have the athlete heart. This group might have the LA and RA dilatation. The optimal image is quite important because if the image is suboptimal window, so you could not get the LA volume index accurately. Okay, the next one is the M mode. Okay, from the M mode, this one you cut the M mode by press at the level of the mitral valve. You might see in this picture. Normally, as we told you, to start from the end of T wave. You see this one. Start from the end of T wave. It's the diastole. This one, the mitral valve. Diastole, the mitral valve is opening. Start from this one is the IVRT. Then to the second phase when the LV pressure is lower than LA pressure. The mitral valve opening, both anterior and posterior leaflet. It starts the second phase is called the E or early rapid filling. When the pressure between LA and LV is equal, it starts the third phase. This means the diastasis that I told you. When the pressure is quite equal, so the mitral valve is closure, but it's not completely closure, like this one. In this phase, it's called the diastasis. There is a slight flow in this phase. Then you see the P wave. P wave is mean the atrial kick or atrial contraction. It starts the last phase of the diastole. It's called the atrial contraction or A wave. So in this one, you might see in the normal M mode across the mitral valve level. So when you press the M mode at the mitral valve level, see this one, E, A, E the very rapid filling, and then diastasis here, diastasis, and then the last one, atrial click, that A. This is the normal M mode at the mitral valve level. But the patient who has the diastolic dysfunction or has the high LA pressure, you might see in this one. This one is called the B bump. Okay, again. Okay, sorry. Okay, from this picture, you see this one is the EPSS. EPSS is mean the E-point septal separation. This point, the normal number should be less than 6 millimeter. This is normal. But the patient who has a LV dilatation, E-point septal separation is over than 6 millimeter. And you might see the B bump. This one is the B bump. B bump is mean the patient have the high LA pressure. So if you look back this one, if the patient has the normal LA pressure, this line should be flat. But if the patient has the high LA pressure, this would be it's like a hump, so it's called the B bump. This represent the high LA pressure. Okay, this one you see the M mode at the mitral valve level. Normally, you should not see this one. You should see is in the flat line and the descending slope from the A wave. Okay, this is M mode across the mitral valve level. Again, you see this end of T wave here. To start the diastole. This the first one is the IVRT, and then the second one is the E wave, early rapid filling. Then go to the diastasis in the third phase, and then the fourth phase is the A or atrial contraction, and then descending flat line. Then this mitral valve is the complete closure in this phase to start the systole here. Normally, you should not see this hump. So if we see the hump at the end of the A wave, this one is called B bump. It represents the increase the LA pressure. Okay, the next one. This is important because it's commonly used in the clinical practice to evaluate the LA pressure or LV filling pressure. It's the mitral inflow velocity. How to obtain the mitral valve inflow? You start from the apical 4-chamber or apical 2-chamber, but most commonly is we use the apical 4-chamber. Okay, and then we use the zoom to the mitral valve and just and place the sample volume and use the pulse wave. As we talked as the last week, pulse wave and CW or continuous wave. If you want to evaluate the flow as the sum point, you must use PW or CW.
PW.
Yes, because you want to evaluate the flow at at some point. So you use the PW and you press the PW at the tip of the mitral valve and use the low wall filter and optimal spectral waveform. I think you should try to practice this one that make you get more something in the practice. Okay, at this one, typical for chamber view, you get this image, and then you press the zoom mode to zoom in this area. When you zoom in this area, the most important thing, one thing, you choose this line, as we talked the last week, you choose the most parallel at the direction of flow. What about the accept angle? How many angles should not be over this number? That's make the evaluation is inaccurate.
You need less than 20.
Very good. Okay, perfect. So you check the direction of flow and the direction of the sample volume that you press. Okay, when you press the pulse wave, you may get this picture. Okay, it's like this picture. Okay, what this picture mean? Okay, you see this one, and you look at the ECG as the reference. Okay, this one is the end of T wave. Start this first phase. What is this phase? It's called the IVRT. It's the Volumetric Relaxation. When the LV pressure is lower than LA pressure, this one mitral valve and tricuspid valve opening. Start the second phase is the E wave, is the early rapid filling. When the pressure LV and LA is equal, it starts the third phase is the diastasis. And the last one, after the P wave, is the atrial click. It starts the fourth phase. It's the atrial contraction, is the A wave. In this one, you can measure the time. And this one is the IVRT, is the Volumetric Relaxation time. And this one is the A duration. Start from the initial A to the end of the A wave with the A duration. And this one from this from the end of the A wave to the next generate dropper during systole is called the IVCT. And the next one is in this phase is the systolic ejection period. Again, have you got this picture? You got it, or you have any question? Please let me know. This is the basic physiology. If you know the basic, when you see something abnormal in this one, you might get, oh, this patient has something abnormal about the diastolic dysfunction. Okay, go to the next one. This picture shows you the Okay, how important to press the correct sample volume, because if you see the correct size, you have to press the sample volume at the tip of the mitral valve level. So it's number 2. If you press the sample volume in the number 1, number 3, or number 4, as you see in the picture here, number 1, number 2, number 3, number 4, you see all these 4 pictures, what the difference between all of this. If you press number 1 under this one, you see it's different from number 2. Number 2 is the correct size of the sample volume. You see the peak E and peak A velocity is different from this one, from all of this. So that's why you should press the correct sample volume at the tip of the mitral valve level. You might get the good number of the E and A. If you press the wrong sample volume, you will get the incorrect number, incorrect measurement. So the technically is you should record 3 consecutive beats during whole breathing at the end of expiration. Okay. Sometimes we might see the fused E and A wave in the MV inflow. You see this one, this one. Okay, from this picture, you see normal E and A wave, but in the arrow point here, you see the fused E and A wave. What happened at this the arrow point is different from the other ones. In this condition is called the fused E and A wave. Some conditions we see the fused E and A wave. For example, is the PAC, is the premature atrial contraction. You see at the beat of the arrow point here, the patient is have the PAC. You see is different from the other one. This one you see, the P wave here, but this group, this cycle, the P's come earlier, is called the PAC. When the patient has PAC, you might see the fused E and A wave, and this beat is the normal sinus rhythm. The P wave is not come earlier, so you see E and A separately, right? This one. But this beat has a PAC, so E and A is fused. The other condition that you could see the fused E and A wave is a tachycardia. Sometimes during the evaluation, the echo, the patient who have the sinus tachycardia, for example, is a heart rate about 110, 120, you might see fused E and A wave. So this one, you choose solution by you adjust the sweep speed from the echo. You might get the picture that separate E and A wave. You should try adjust the speed, sweep speed of the imaging. The other condition you might see the fuse and E and A wave is the heart block. Any degree of heart block, for first, second, or the third degree AV block, you might see the fuse E and A wave. This picture is quite important. Okay, this one is the L wave. Normally, you see E. This one is the third phase diastasis, and A. Sometimes we see the diastatic phase is prominent. This one, if it's prominent, is called the L wave during the diastasis. This one is mean the patient have the high LA pressure. For example, this picture show you see this picture. Normally, we would see E and then diastasis here and A wave. If the patient has a prominent at the third phase or the diastasis, so it means the patient has flow in this has a exaggerated flow during the diastasis phase. That means the LA pressure is very high, so you will see this flow during the third phase or the diastasis. It represents the high LA pressure. So in the third phase, LA pressure and the LV pressure, it should be equalized. It should be equalized. But if the patient have the high LA pressure, the LA pressure is still main higher than LV pressure. That's why we can detect the flow in the diastasis phase. It's called the L wave from the mitral valve inflow velocity. The L wave is can divided into the physiologic L wave is the normal and pathological L wave. Physiological L wave we can see in the patient who have the significant bradycardia. For example, in the young athlete who have the sinus bradycardia, the heart rate about 40 or 50 beats per minute, you can see the L wave. But the normally physiologic L wave, the velocity is mean if you press here, the velocity should be less than 20 centimeters per second. But the pathological L wave is the prominent L wave, and the velocity is over 20 centimeters per second. And this one is the abnormal, and it represents the high LA pressure. So if you see the L wave, you should classify it as is a physiologic or pathological abnormal by you use the L wave velocity. Normal, it should be less than 20 centimeters per second. And you see in the patient, in the young athlete, and the heart rate is quite slow. Okay. The next one is the from this one, you from the MV inflow, you measure the IVRT and the decelerating time. Decelerating time is you measure from this one. You get the E wave and you measure E, and you draw the picture, trace here to here. The machine will auto calculate the decelerating time, and you will get the number in this one at this angle in this one from the screen. Okay, IVRT and decelerating time. Okay, this one is the picture you get from the MV inflow. You see this one, you press the sample volume at the tip of mitral valve level. This is the correct picture and the correct the sample volume press the correct size. Okay, get this one, E and A. Why you know this E, why you know this A? You use ECG as the reference. The diastole starts from the end of T wave. So at the end of T wave is followed by the E, and then followed by the P wave is the A. From this picture, you measure this one. It's called the IVRT, and then this one is the P wave, is the A. If you measure duration from this one to this one, it's called the A or A duration. This picture is look normal because this the E wave and this is the A wave and this one is the diastasis phase. No flow in this phase is normal. You don't see the L wave from this one, so this patient is highly to have no high LA filling pressure. Okay. Any question? This one is you should know about all of the parameter from the mitral valve inflow, and this is IVRT and DT. Okay. What is the decelerating time? Decelerating time is the time during the peak of your E wave to the end of E wave is called the decelerating time. Normally, in the early stage of the diastolic dysfunction, this time is a little bit prolonged, but in the late stage, this time might be shortened because in the late state of the diastolic dysfunction, the LV pressure is very high. So the LV pressure is very high. The LA pressure fill the back to the LV is take a time very short. So that's why in the late state of the diastolic dysfunction, the decelerating time is very short. This means that's why you have to measure the DT or decelerating time is used as the one parameter to determine the state of the diastolic dysfunction. Oh, okay. One thing you should concern the decelerating time in this setting, you should not apply DT in the setting with the atrial factor. The next one is the fused E and A wave. One thing when you measure peak E and peak A velocity, peak A velocity, when the initial A, the velocity is over than 20 centimeters per second. This one, you should adjust the sweep speed to separate between E and A wave out. If you measure the peak A velocity in this picture, this one, at the initial A, velocity is over 20. This one, you might get the over number of the A velocity. So if you see this picture is the fused EA, you should adjust the sweep speed to separate between E and A. And then you measure E, peak E wave and A wave again. Okay. When you obtain the mitral velocity, you measure peak E, peak A, and then measure the IVRT and measure the decelerating time. And you use all of these parameters to grading the diastolic dysfunction from the normal diastolic function. E A ratio, it should be about the 1 to 2. You see this one, normally E over A, E over A, and the ratio is about 1 to 2. And the IVRT is the time Volumetric Relaxation time. Normally the number is about 70 to 90 milliseconds. And DT normally is the 150 to 240 milliseconds. This is the normal number. In the routine practice, we have not, it's not absolutely need to remember this number. It's just okay, just remember briefly, roughly about what about the top number or the low number. Okay, when the patient who have the grade 1 diastolic dysfunction, grade 1 is the abnormal relaxation. Abnormal relaxation is mean when the patient who start with a little stiffness of the myocardial. The myocardial is have abnormal relaxation. When the patient have abnormal relaxation, so the E wave velocity is decreased and the A wave velocity is increased. This is the grade 1 diastolic dysfunction or the abnormal relaxation. So the EA ratio is less than 1. In this phase, IVRT is over than 90 and the DT is slightly prolonged, is over 240. This is the grade 1 diastolic dysfunction. Have you got this one? เข้าใจไหมครับอันนี้ มันจะเข้าใจยากหน่อยนะ
ขออีกทีได้ไหมคะอาจารย์
โอเค Again, look back to the normal. Normally, as we talk about, mostly of the blood flow in the second phase of the diastolic state is the E wave. Normally, E should over than A because normal blood filling mostly occur during E phase or second phase. So the EA ratio should be about 1 to 2. The ratio, this number is 1 to 2. and the IVRT normal number is about 70 to 90, and the normal DT is about 150 to 240 millisecond. The time unit is a millisecond. Okay, when the patient who have started diastolic dysfunction, this will start from the abnormal relaxation. When the abnormal relaxation is the grade 1, this parameter will be changed to abnormal. So when the patient who has the abnormal relaxation, when the LV is abnormal relaxation, the E-wave velocity is decreased because the LV is abnormal relaxation, abnormal to relax, to fill the blood. So it's abnormal relaxation and abnormal to fill the blood. The E-wave velocity is decreased and A-wave velocity is increased. You try to imagine when the LV has an early stiffness, the relaxation is abnormal. So the process to filling the blood is changed to abnormal. And then from this phase, as I talk to you, is the most important phase. But when this phase is abnormal relaxation, so the velocity to fill the blood is decreased because the LV relaxation is abnormal. So when the E is decreased, the A or atrial is take the action to compensate the abnormal LV relaxation. That's why the E wave is decreased and the A wave is increased in the early phase of the diastolic dysfunction. So the E and A ratio is decreased to less than 1. This is the first state of grade 1 diastolic dysfunction. When the relaxation of the LV is abnormal, then the IVRT is prolonged a little bit, so it's over than 90. And also when the E wave is a little bit abnormal and E wave duration is also prolonged, so that's why the DT is prolonged a little bit. The time is over 240. This is called the grade 1 diastolic dysfunction. Have you got it?
เข้าใจแล้วอาจารย์ขอบคุณนะคะ
โอเค ถ้าไม่เข้าใจบอกได้เลยนะ ตรงนี้มันยาก ต้องค่อยๆเข้าใจ โอเค When start with the grade 1 diastolic dysfunction and when we take a long time for the grade 1, when the LA pressure is after the long term of the grade 1 diastolic dysfunction, you see the LA volume is increased and the LA pressure is increased because it's back pressure to the LA when the LV abnormal relaxation. So the filling the blood to the LV is not good. Then it's back pressure to the LA. The LA is accumulate more volume and more pressure for a long time. Then it starts the grade 2 diastolic dysfunction. It's called the pseudo-normalization pattern. When the grade It take a long time. It's back pressure to the LA. The LA is take action for the long time. It will start with breakthrough diastolic dysfunction. So when the LA pressure is very high, when it starts the second phase of diastole is the E. The E it will show the exaggerated E wave velocity again. The E will overcome the A wave again because you imagine when the LA pressure is high, higher than usual. When the mitral valve opening start the second phase of the diastole, the blood from the LA is come to it's filter the LV is take a time where is the blood from the LA to the LV is come very quickly because the LA pressure is very high on the long term accumulate after the grade 1. When the LA pressure is very high, when it's filled but in the E wave, so that's why it's changed from the grade 1 to grade 2. E from the grade 1 is changed to the grade 2. That's why the E wave is over the A wave again. งงไหมครับ อย่างนี้นะ จากเกรด 1 เนี่ย ปกติเนี่ย LV abnormal relaxation ถูกไหม มันก็เลยทำให้การคลายตัวมันไม่ดี มันก็เลยทำให้เลือดที่ฟิลจาก LA ลงไป LV มันทำได้ไม่ดี มันก็เลยทำให้ E wave เนี่ยมันต่ำในเกรด 1 พอเมื่อไหร่ก็ตามที่มันฟิลบัตได้ไม่ดีในช่วง E คือ second phase เนี่ยมันก็เลยทำให้ A wave ต้องมาทำหน้าที่ compensate แทนเยอะๆ A wave velocity ก็เลยสูงกว่า E ในเกรด 1 พอเข้าสู่เกรด 2 ปุ๊บ หลังจากที่ long standing เกรด 1 ไปนานๆ LA pressure มันก็จะสูงขึ้น เพราะ LA pressure ต้อง take compensate action จากตัว E wave ไปนานๆ มันก็เลยทำให้ LA โตขึ้น LA volume ก็มากขึ้น LA pressure ก็สูงขึ้น พอ LA pressure สูงขึ้นในระดับหนึ่ง มันก็จะทำให้ E wave กลับมาสูงเป็นปกติ แต่มันไม่ปกติ การที่ E wave กลับมาสูงแล้ว E A ratio over than 1 again เนี่ยเกิดขึ้นจากการที่มันมี high LA pressure. So in the grade 2 diastolic dysfunction is caused from the long-term higher LA pressure. That's why E become over A again in the grade 2 diastolic dysfunction because the high LA pressure after the mitral valve open, the blood flow from the LA to the LV is very quickly. That's why the E wave velocity is increased again in the grade 2. So the ratio in the EA ratio in the grade 2 is about 1 to 1.5, and the IVRT is shortened again, is less than 90, and DT is about 150 to 200. Okay, when the grade 2, this is a continuous process. If the patient has some pathological abnormal without any correction, this continuous process will go on and go on. When the grade 2 is progress to the grade 3. Okay.
อาจารย์คะ
โอเคครับ
ขอโทษนะคะคือเมื่อกี้ทำไม E มันถึงสูงกว่า A นะคะคือพอ pressure ตรง left atrium เยอะขึ้นทำไมถึงทำให้ E มัน เยอะขึ้นนะคะ
when the LA pressure is high, the blood will transport from the high pressure to the low pressure. When the LA pressure is very high, it look like the balloon filling the water in the balloon, and you compress the balloon from the outside. If it's similar to high LA pressure, when the mitral valve open, the high LA pressure, the blood is filled from the LA to the LV very quickly. So that's why the E-wave velocity is increased again from the high LA pressure. เข้าใจไหม
อ๋อเข้าใจแล้วค่ะ
เพราะมันสะสมเพรสเชอร์มานานทำให้ LA pressure สูงขึ้น จากเดิมที่มันแค่เป็นแค่เกรดหนึ่งพอมันนานเข้า LA pressure มันสูงขึ้น พอ LA pressure สูงขึ้นไปถ้าวาล์วเปิดเลือดมันก็เลยฟิวลงเข้าไปใน LV ค่อนข้างเร็ว เพราะ LA pressure มันสูงเลือดมันก็เลยเหมือนถูกบีบมันไม่ได้ถูกบีบเพราะ pressure ที่มันสูงนานๆน่ะพอมีที่ไหนให้มันระบาย pressure ออกไปได้มันก็เลยรีบออกไปมันก็เลยทำให้ E-wave กลับมาสูงอีกครั้งหนึ่งแต่ D ต่อ A ratio ในเกรด2เนี่ยส่วนใหญ่มักจะอยู่ในเลนประมาณ 1-1.5 Okay, and then grade T, when the grade 2 progress to the grade T, when this progress, this means the LA pressure is the accumulate the high pressure. So you might see the E is over than A, the same, but this one, the IVRT and DT is the very, very short. In the grade T, the IVRT is less than 70 and the DT is very short. As I told you, when the LV pressure is high and the LA pressure is also high, the LV pressure is high and LA pressure is high. So the blood flow from the LA to LV is take a time very short. It take a time to equalize pressure between LA and LV is very short. So the E and A wave ratio is also about over 1.5. And then the IVRT and DT is very, very short than usual. Because IVRT is very short because the LA pressure is very high. When the LA pressure is very high, it take a shorter time to lower the pressure below the LA pressure. Like the DT pressure, because the LV pressure is very high, so the the blood flow from LA to LV is take a short time to equalize pressure between LA and LV. งงไหม IVRT คือ Volumetric Relaxation Time คือเวลาที่ใช้ในการทำให้ LV pressure มันต่ำกว่า LA pressure ทีนี้คนไข้เนี่ยปุ่มเนี้ย LA pressure มันจะเริ่มสูงแล้วเห็นไหมมันรีแลกซ์แป๊บเดียวแล้ว LV feeling มัน LV pressure มันก็สูงแล้ว LA pressure มันก็สูง LV pressure ที่สูงเนี่ยมันนิดเดียวมันรีแลกซ์แป๊บเดียวตอนถ้าวอร์มมันก็เปิดแล้ว และ LA มันก็จะเติมเลือดเข้ามาใน LV ทีนี้พอเวลามันเติมเลือดเข้ามาใน LE เนี่ยมันจะ equalization pressure กันเร็วมากมันก็เลยทำให้ช่วง E velocity ช่วง early rapid filling time เนี่ยมันก็จะสั้นไปด้วยเพราะ LV มันสติ๊กปุ๊บมันเติมเลือดแป๊บเดียวมันก็ pressure ระหว่าง LA LV มันก็เริ่มเท่ากันละพอมันเท่ากันหมายความว่า E wave ตัว E wave timing เนี่ยมันก็จะสั้นลงมันก็เลยทำให้ DT เนี่ยสั้นลงไปด้วยพอเป็นมากเข้าก็จะเป็นเกรด 4 จริงๆแล้ว in the grade 3 and grade 4 is the same but the difference between grade 3 and grade 4 is reversible and irreversible in the grade 3 is can reversible to the grade 2 or grade 1 or but the grade 4 is the irreversible process is the fixed process so if the patient has grade 4 is the restricted grade 3 and grade 4 is the restricted pattern okay to look on the next slide that make you the more understand this one some limitation of the MV inflow because it's the preload dependent so when you evaluate the patient you should look on the heart rate you should look on the volume status of the patient if the patient has a high heart rate for example is the sinus tachycardia you might see the fused E and A wave you should separate E and A wave by the adjust the sweep speed in the button of the echocardiogram. The next one, the correct side to press the sample volume is the crucial because if you get the wrong side, you might get the wrong picture of the E and A wave. Okay. Okay. You want to take a break? 5 minutes. Oh. Okay, let's take a break for 5 minutes and come back again about the 1047. Any question? งั้นพักก่อนนะครับ เดี๋ยวจะเบลองงไหมครับ ถ้างงตรงไหนบอกใหม่ได้นะ เรื่องตรงนี้มันต้องใช้เวลาทำความเข้าใจจริงๆ Okay, let's come back again. Okay, this again for the diastolic dysfunction, grade 1, grade 2, grade 3, and grade 4. C is the grade 3 and grade 4 is called the restrictive pattern. It's high LV filling pressure, high LA pressure. You see the E and A ratio is over 1.5 and the short IVRT and short DT. And the grade 3 and grade 4 this can divide is different from the grade 3 is a reversible process, but the grade 4 is called when it's a reversible process. How to separate between the grade 3 and grade 4? We use a Valsalva maneuver. You know the Valsalva maneuver? Valsalva maneuver is when make the patient perform the Valsalva maneuver, you explain the patient as take a deep breathing in and then try to breathing out without the flow out from the lung. So you mean you try to force expiration without the air flow out from the lung. It's how to perform the adequate Valsalva maneuver. The Valsalva maneuver is divided into the four phases of the Valsalva maneuver. It's useful in the diastolic evaluation because it can separate the grade 2 and the normal. As I show you this one. Okay, we use the Valsalva maneuver to classify between grade 3 and grade 4 and also the grade 2 and normal. You see, the grade 2 E over A is same like the normal diastolic function E over A. We use the Valsalva maneuver to separate between grade 2 and normal and differential between grade 4 and grade 3. What's the Valsalva maneuver? There was four phases in the Valsalva maneuver. The phase 1, when you try to force expiration, is increase the interthoracic pressure. When the interthoracic pressure is increased, the blood come back from the systemic circulation back to the right side of the heart is decreased because the interthoracic pressure is increased. When the interthoracic pressure increases, the blood come back to the right side of the heart is decreased. When the blood come back to the right side is decreased. You see this way. The full line is the pressure, and the dashed line is represent the heart rate. When you start Valsalva maneuver, the first phase, to force expiration without the airflow out from the lung. The first one, you might see the pressure is a little bit increased in the phase 1 because you force expiration, the blood in the lung is squeezed from the lung back to the heart, past the pulmonary vein into the LA. When the blood back to the LA is increased a little bit from the squeezed lung, so the blood come back to the LA, to the LV is increased. That's why in the phase 1 of Valsalva maneuver, the pressure is increased. After that, intrathoracic pressure increased, so the blood return back to the right side of the heart is decreased. Then the blood to the lung and to the left side of the heart is also decreased. That's why in the second phase, we see the pressure is dropped down. The systemic blood pressure is dropped down. When the systemic blood pressure is dropped, we compensate the drop the blood pressure by the increased heart rate. So that's why when the patient perform the Valsalva maneuver about 5 to 10 seconds, you might see the patient, the heart rate is increased, but the pressure is decreased. So when the blood pressure is decreased, the blood volume back to the left, to the lung and to the left side of the heart is also decreased. This one is very useful and help us to differentiate between grade 2 and normal, and between grade 4 and grade 3, because we apply this physiology to differentiate between both, because the decreased blood return to the heart and decrease the blood volume, that's can separate both situations. So this is when you see the MV inflow with Valsalva. This one, if you start the Valsalva maneuver here, after that about 5 to 10 seconds, you might see the heart rate is increased, because this is a phase 2 of the Valsalva maneuver. You see the heart rate is increased from the compensation of the blood pressure drop. Then you see the volume back to the heart is decreased, and also the volume to the lung and to the left side of the heart is decreased. So then you might see the blood pressure that across the mitral valve is also decreased. This is we use this physiology to apply in the MV inflow from the echo. So how to evaluate this patient perform the adequate Valsalva maneuver. If the patient perform with the adequate Valsalva maneuver, you might see the facial flushing. The face of the patient is the redness. Or sometimes you see the distend the neck vein, because you see intrathoracic pressure is increased, the blood return back to the heart is decreased, so it's back pressure to the venous system. So you might see the distend the neck vein, or increased abdominal tone. You see the rigid abdominal muscle. If you take the Doppler from the MV inflow, you might see the E-wave velocity is decreased, because the blood return back to the heart decrease. The blood go to the left side heart also decrease. Might see the E-wave velocity is decreased. Okay, the Valsalva maneuver we use to, as I told you, to differentiate between the normal and the pseudo-normalization is the grade 2 diastolic dysfunction, and also used to differentiate between the grade 3 and grade 4. Grade 3 is the reversible process, and the grade 4 is the irreversible process. Okay, then Valsalva maneuver. Valsalva is used to decrease the preload. That's impact to decrease the flow across the mitral valve. That's decrease the EA ratio. When the E wave velocity decrease, the E and EA ratio also decrease over 50%. This one is called the grade 2. Sometimes we obtain the mitral valve inflow Doppler the patient. You get this one. You don't know this is the grade 2 or this is the normal, because grade 2, the EA ratio is about 1 to 1.5. In the normal patient, you can get EA ratio about 1 to 2. So how to differentiate? If you see the patient, this patient is a LA is enlargement or the high LA volume index. So you might suspect this could be the pseudo-normalization or grade 2 diastolic dysfunction. So you give the patient to perform the Valsalva maneuver to differentiate between this. If you give the patient perform the Valsalva maneuver and you obtain this image, you see, perform the Valsalva and you obtain the MV inflow again, you see the E is decreased. So this patient is the grade 2 diastolic dysfunction. It's not normal. But if the normal patient, if the patient to perform the Valsalva maneuver, you still get this E over A. This is the normal. But if you give if you obtain the image, E is significantly decreased and EA ratio less than 1, so this patient has the grade 2 diastolic dysfunction. Normally, when the patient performs the Valsalva maneuver, the E wave is slightly decreased, but E is still over A. This is the normal. But the grade 2 E wave velocity is the exaggerated decrease to over 50%, and sometimes E less than A. Okay, this is the grade 2 diastolic dysfunction, is the pseudo-normalization pattern. Okay, you see this one? Okay, if you start the MV inflow, this one, you see? This, you look at the EKG, this E, this A, E, A. When the patient start performing the Valsalva maneuver, what you see? E, A, E, A. You see the E wave is decreased to here. A, E, A, E, A. You see the E wave is significantly decreased over 50%. So this patient has the grade 2 diastolic dysfunction. After patient perform the Valsalva maneuver, we use the second phase of the Valsalva maneuver to differentiate between grade 2 pseudo-normalization and normal, and also use to differentiate between grade 4 and grade 3 diastolic dysfunction. In the grade 4 and grade 3 diastolic dysfunction, in the grade 4 and grade 3, if you see the high EA ratio and short DT and short IVRT, when give the patient to perform the Valsalva maneuver, if the E wave velocity is significantly decreased over 50%, so this patient may have the grade 3 diastolic dysfunction because it's the reversible process. After you decrease the volume across the mitral valve. In the practice, it means the patient that has a high LV filling pressure and high LA pressure. After give the patient with the diuretic and patient get more the urine out, so the LV filling pressure is decreased and the LA pressure decreased. This group of patients is the grade 3, the diastolic dysfunction. We perform the echo by use the Valsalva that's the imitate the clinical picture of the patient who have the high LA or high LV filling pressure. Have you got this one? เข้าใจไหมอะครับว่าทำ Valsalva เพื่ออะไรไหนลองตอบสิครับเข้าใจไหมเอ่ยตรงนี้หรือว่าเริ่มงงละ
เอาไว้ช่วย separate grades หรือเปล่าคะ
ใช่หลักการก็คือ the main concept of the Valsalva maneuver is increased intrathoracic pressure. Then the blood return back to the heart is decreased. The volume back to the heart decreased. So the E velocity should be decreased a little in the normal patient. But in the patient who has the grade 2 diastolic dysfunction, E wave is significant decrease. Mostly is change over 50% decrease. เข้าใจนะครับเราก็เอาไว้แยกเกรด 3 กับเกรด 4 Okay. The next one. Okay.เห็นอยู่ใช่ไหมครับเห็นจออยู่เนาะโอเคเมื่อกี้จบเรื่อง Mitral Valve inflow ไปแล้วก็ about the MV inflow you should know about the EA ratio IVRT and DT the next one we'll have to learn about the tissue Doppler imaging. Tissue Doppler imaging is you see the blood button in the echocardiography is the TDI. What's about the TDI? It's when to perform, you use point the sample volume at the medial and lateral parts of the mitral valve annulus. You switch the pulse wave TDI and record during the breath holding at the end of expiration. You might get the image. It's a S palm, E palm, and A palm velocity. This might help us to grading the diastolic dysfunction too. The tissue Doppler imaging, you press the sample volume at the medial annulus and the lateral annulus of the MV annulus. So this one, you start from the apical four-chamber view. This is the medial annulus. You press the sample volume in the medial annulus. Again, you should concern about the Doppler angle acception. You should press the most parallel as you can. This is a medial annulus, and the next one, you press the lateral annulus and press the TDI button. I get then again, and then press the pulse wave to get the image here.ต้องลองไปทำดูถึงจะเห็นภาพ Again, you obtain the image in the apical four-chamber view. Then press the TDI and press the sample volume at the medial annulus here and take the direction of the sample volume, the most parallel of the annulus direction movement. Then you press the pulse wave, you get this image here. Okay. You get this image. What is this image mean? Okay. This one is the S palm. S is the systole. It's the tissue Doppler during systole. It's called the S palm. During the diastole, it looks like the MV inflow. It shows the E palm and A palm wave. E palm is the early rapid filling, and A palm is the atrial kick. So the IVCT is start from here at the end of the A wave to the before of the initial of the S wave. This is the IVCT, and the duration of the S wave is the systolic phase. And then at the end of the S wave to the initial of the E palm wave is called the IVRT.ไม่งงนะ มันจะคล้ายๆกับ Mitral Valve Inflow ล่ะ Okay. You obtain the image from the medial and lateral tissue Doppler. You might get this number S palm, E palm, and A palm also. Normally, the lateral E palm should be a little bit more than the medial E palm. One thing you should concern about the TDI is the angle dependent. As I told you, the accept angle should be less than 20 degrees. Normally, the lateral E palm should be over than medial E palm, except in some condition that the medial E palm is over than lateral E palm. For example, is the condition is called the constrictive pericarditis. This means the chronic inflammation of the pericardium. When the chronic inflammation of the pericardium is stiff and quite rigid, and the lateral annulus is attached to the pericardium. So in the constrictive pericarditis, the lateral E palm velocity should be less than the medial E palm. That is the abnormal condition. Because the normal condition, the lateral E palm should be over the medial E palm. Okay, when you obtain the image from the medial and the lateral E palm tissue Doppler velocity, we use this to classify the diastolic dysfunction to grade 1, grade 2, 3, and 4, similar to the MV inflow Doppler. Normally, you see this image here. Okay, normal. In adult normal patient, we might see the E palm over the E palm velocity over than the A palm velocity. When the patient has the grade 1 diastolic dysfunction, you see the E palm velocity is decreased, but the A palm velocity is increased. In the grade 2, same as the grade 2 diastolic, same as the grade 2 from the MV inflow. You see, E palm is again a little bit increased and A palm is a little bit decreased. When the grade 3, E palm is decreased and A palm is also decreased, and grade 4, E palm is E palm is exaggerated decreased and A palm is also decreased too. Again, grade 1, E palm normal, E palm over A palm. In the grade 1, E palm decreased, A palm is a little bit increased. Grade 3, E palm still be same and A palm decrease, and grade 3, E palm decrease, A palm decrease, and grade 4, E palm and A palm decrease. This means when the process, all of this process is a continuous process. When the myocardium is stiff and the mitral valve annulus is also stiff too, then the tissue Doppler is represent the MV annulus movement. When the left ventricle is stiff, so the movement is decreased. That's why the MV annulus that detect from the tissue Doppler imaging is also decreased. This is the tissue Doppler imaging. So we also accompany look with the MV inflow. See, normal E over A and tissue Doppler is show the E over A palm, E palm over A palm. In the grade 1, E palm decrease and A palm is a little bit increased. It's similar to the MV inflow, E decrease and A increase. In the grade 2, E palm is increased again and A is decreased. But in the tissue Doppler imaging, E palm and A palm is also decreased. So the TDIs that help us to differentiate between grade 2 and normal, because normal E palm is over A palm, but in the grade 2 the diastolic dysfunction, E palm and A palm is different, decreased both. But you see in the MV inflow, you see E over A. But the tissue Doppler imaging in the grade 2 diastolic dysfunction, E and E palm and A palm both are decreased. Okay, so you should use this one to differentiate between grade 2 and normal. About the grade 3 and grade 4, the grade 3, E over A both, and grade 3 and grade 4, the DT and IVRT is very short. In this group, you might see the tissue Doppler imaging, E palm and A palm is very low, just velocity about 3 to 4 centimeters per second. This is a grade 3 and grade 4 diastolic function. So we use this E to E palm ratio to correlate with the LV filling pressure. This study from the Dr. Nage from the Mayo Clinic. He used the standard LV filling pressure from the insert catheter to measure the LV filling to measure the LV filling pressure from the intracardiac cath directly and correlate with the E to E palm ratio. E we get from the mitral valve info and E palm we get from the tissue Doppler imaging. This E to E palm ratio is correlate well with the LV filling pressure. So if the E to E palm ratio is over 15, it represent the capillary bed pressure over 20. So if you use E to E palm ratio over 15 from the medial annulus, if this number over 15, it means this patient likely to have the high LV filling pressure. So that's why we use this E to E palm ratio to evaluate the LV filling pressure of the patient. Sometimes this E to E palm ratio is unreliable in some condition that show you in this slide. It's unreliable event caused from the technical error. For example, if you malplacement of the sample volume or miss the right respiratory phase, you haven't got the picture from the end expiratory phase. You might get the inaccurate Doppler imaging. Sometimes you see the fused E and A wave. You might correct it by adjust the sweep speed. Or sometimes if the patient have the significant MR, sometimes this E wave velocity is unreliable. And this you should remember unreliable palm is caused from the one is the technical error, and the second one is from the patient who have the mitral valve repair. So the patient who have mitral valve repair with the annulus artificial, which use the annulus artificial repair with the mitral valve annulus. So the annulus of the mitral valve is locked. That's the movement of the mitral valve annulus is limited. So that's why we should not reliable the E palm velocity because we might get the E palm velocity less than usual. So this condition we should not use the E palm. The other one is the heavy mitral annular calcification. This look like the mitral valve repair because the heavy calcification around the mitral annulus limits movement of the annulus. That's why this condition E palm is unreliable. The other condition is the significant mitral valve stenosis. The patient who has significant MS might have the limits excursion of the annulus. The other condition is the patient who have the left bundle branch block or the pacemaker rhythm. This condition, E palm, is also unreliable. And also the pericardial disease that I talked to you before is the constrictive pericarditis. Normally, medial E palm it should be over than lateral E palm. In the constrictive pericarditis, the lateral E palm is over the medial E palm. So that's this condition, the E palm to evaluate the LV filling pressure is unreliable. It is unreliable. Okay, we finished the mitral info and the tissue Doppler imaging. The next one is harmonic rainfall. Okay, before you go to the next one, any question? Wow. Any question, please? Okay, assume no question. Okay, the next one is harmonic rainfall. You see the harmonic vein is connect to the left atrium. So if you want to evaluate the diastolic function, we can evaluate the flow from the harmonic vein. That's that it can represent the LA pressure in some situation. Normally, it's a harmonic vein have 4 harmonic veins. In the right, have 2 right upper and right lower. In the left side is the left upper and left lower. Both of 4 harmonic veins is connect to the left atrium. How can we get the harmonic vein from the echo? Okay. You see this one is the apical 4-chamber and apical 5-chamber view. You obtain the apical 4-chamber view. You might get some flow here. Is this a light upper and light lower pulmonary vein? Okay. Again, start from the apical 4-chamber view and zoom at here. If you tilt up the probe, you might see the aorta. And you might see the flow here. This flow is the move away from the atrial septum. This one is the right upper pulmonary vein. Okay, and if you tilt down to the 4-chamber again, you might see the other flow that's move parallel the atrial septum. This is the right lower pulmonary vein. Okay, this is a right upper and right lower pulmonary vein that we can obtain and use this vein to evaluate the harmonic rainfall. Okay, from this one, you see this is the apical 4-chamber view, and you zoom in this point. You put in the color flow. You see this one is the right pulmonary vein. And you press the sample volume here, put deep into the pulmonary vein about 2 to 3 millimeter. Here, zoom in and press the sample volume. Okay. When you press the power wave Doppler PW, you get this Doppler image of the pulmonary vein. Normally, you get this image. It's called the Doppler S1, S2, D, and A reversal. What is the S1, S2, D, and A reversal? S1 is the early systole, S2 is the late systole, D happened during diastole, and AR is the A reversal. This occurs during the atrial contraction. When the atrial contraction, blood is pushed out from the left atrium. most of the blood is go to the left ventricle, and a little bit blood is back to the pulmonary vein. Is called the A reversal. Okay. This is a Doppler image of the pulmonary vein. S is the PVS1, S2, D, diastole, and A reversal is caused from the atrial boost or atrial kick. What is the S1? S1, it happened during the LA relaxation. You try to imagine during the ventricular systole, the left atrial is relaxation. When the left atrial relaxation, the pressure in the LA is decreased, so the blood is filled from the pulmonary vein to the LA. It generates, this one is the pulmonary PVS1, caused from the LA relaxation. Okay, when the LA relaxation generate the PVS1 and then generate PVS2. PVS2 is caused from the continuous flow from the pulmonary vein go to the LA. This one. This one, when during systole, the RV systole is puts the blood from the RV to the lung. Then the blood in the lung is continue squeezing back to the LA. It generate the PVS2. PVS2 is caused from during the heart, the right ventricle contraction and push the blood to the lung, and the consequence of the flow is back to the LA. It generates the PVS2. Then, when ending the systole, it starts the diastole. During the diastole, the mitral valve open, so the flow from the LA to the LV, and then the flow from the pulmonary vein is the flow to the LA also. This is the generate the PVD Doppler. Okay, then at the end of at the last phase of the diastole is the atrial kick. This generate the LA boost or LA pump. This put the blood to the LV and a little blood back to the pulmonary vein. So we use of the S1, S2D, and AR to correlate with the LV filling pressure. And what's that? Again, S1 is caused from the LA relaxation. S2 is caused from the propagation flow from the right side of the heart. And D is the occur during the diastole or ventricular relaxation. And A is the A reversal flow. Okay. Again, this is a S1 is the LA relaxation. Then is the propagation flow from the right side of the heart. It generates the S2. Okay. When a mitral valve open, it's the diastolic phase. It generates the D pulmonary vein D Doppler. And then during atrial systole is the last phase of the diastole. Some of the blood back to the pulmonary vein. is the A reversal. Okay, normally the S ratio should be over D. The S number should be over D number. If the S less than D, so the S to D ratio is less than 1. This is the abnormal condition. Normal condition S2 over D. Most of the time, we always see the S2. Some patient we could not see the S1 because the S1 is the short period. Sometimes S1 is filled into the S2 period. So when we measure mostly is to measure the S2, PVS2. Normal value, the S2 should be over D. So the S to D ratio should be over 1. In the abnormal patient, S less than D, so the S to D ratio less than 1 is this. This is the abnormal number. Okay. This is a Doppler imaging of a harmonic wave. See, PVS, PVD, and this is a reversal. As I told you, normally S should be over D, so the S to D ratio over than 1. And also, normally we measure the PVA velocity here. You press here, you measure here. Normally, it should be PV velocity should be less than 25 centimeters per second. If the patient has PVA velocity over 35 centimeters per second, it represents the high LA pressure and high LV filling pressure because it's very tough when the atrial is kick the butt to the LV because it's the high LV filling pressure. That's why the butt back to the pulmonary vein more than usual and produce the PVA velocity over than 35 centimeters per second. This is the abnormal number that represents the high LV filling pressure. And we use the PV and we use the different time between the pulmonary vein duration and MV duration. Is this different number over 30 milliseconds is represent the high LA pressure because see is the PV duration is over than usual. It means the atrial is kick the butt to the LV is very tough. So it's the blood is back to the pulmonary vein by the atrial click, and it takes the longer time of the pulmonary vein. You measure by this one. You see this PVA duration is the time at the initial A to the E to the end of the A wave. This is the PVA duration. And MVA duration, how to measure it? You remember it's from the E and A. MVA duration, you measure from this one to this one. This is the MVA duration. So if you use this number minus with this number and this number over 30 milliseconds, this is the abnormal number and represent the high LA pressure and high LV filling pressure. Okay, the usefulness. of the harmonic vein Doppler again. Normally, S should be over D and S to D ratio should be over 1. In the abnormal condition, S less than T, so the S to D ratio is less than 1. And you use the PVA duration minus with the MVA duration over 30 millisecond. Please correct this, is not millimeter mercury. It's the time, is the millisecond. This one is represent the high LV filling pressure. And if we see the AR velocity over 35 centimeters per second, this is also represent the high LV pressure. You see this one? You just point this one and measure the velocity. If this one velocity over than 35 centimeters per second, okay, it represents the high LV pressure. So in the patient with the atrial fibrillation is loss of atrial kick. So in the pulmonic vein Doppler, in the atrial fibrillation, it should absent of the irreversible wave because there is no P wave from the ECG and no atrial kick from the physiology. So it's absent of the irreversible wave. And most of the patients with atrial fibrillation should have the blunted S wave. So the S wave is blunted, so the S to D ratio should be less than 1. Sometimes we use a harmonic vein Doppler to evaluate the pulmonic vein stenosis after the ablation of the atrial fibrillation. Normally, the SD ratio about the velocity is about 40 to 60 milliseconds. After the patient who perform the AF ablation, after that the patient come up with the heart failure and the Doppler imaging of the pulmonic vein Doppler show the increased velocity. You see this one is the 2. The velocity is close to the 2 meters per second. It's the abnormal number. The normal number about 40 to 60 centimeters per second. If the velocity is increased, so this patient should be suspected for the pulmonic vein stenosis post-AF ablation. No, because AF ablation, now with to get rid some abnormal point, triggering point of the AF, that's the site around the pulmonic vein. So when the patient perform the AF ablation, we ablate at around the pulmonic vein. So the complication after AF ablation is the pulmonic vein stenosis. So we use the pulmonic vein Doppler to evaluate the pulmonic vein stenosis if the patient was suspected and come up with a heart failure. Okay, if we integrate all of the parameters, the mitral valve inflow, tissue Doppler imaging, and pulmonic vein flow, if we integrate all of this to creating the diastolic function, okay, the normal mitral valve inflow E over EA ratio about 1 to 2, and the E palm over than A palm, and pulmonic vein Doppler S over D. Oh, one thing you should know, in the young adult, sometimes we can see S less than D. This is the normal in young adult because, in the young adult, the LV relaxation, the heart, the LV is very good compliance. The very good compliance is mean the good suction, good relaxation to suck the blood from the LA to the LV. That's why in the young adult we can see D over S in the young adult. This is the normal in the young adult. So how we can differentiate the pulmonic vein Doppler who has the S less than D. We have to look the other parameter. If S less than D in young adult and E over A, the ratio is about 1 to 2, and tissue Doppler is show S E palm over A palm. So this is the normal pulmonic rainfall in the young adult. เข้าใจไหมครับตรงนี้งงไหมครับหรือว่าหลุดโลกไปแล้วงงไหมเอ่ย
ไม่งงค่ะ
โอเคแยกออกนะสรุปคือว่าในคนอายุน้อยเราอาจจะเจอ S น้อยกว่า D ได้เพราะว่าอะไรเพราะว่า LV ในคนอายุน้อยเนี่ยมัน compliance ดีมัน relaxation ทีมันก็ซักเลือดจาก LA ลงมา LV ได้ดีมันก็เลยทำให้เห็น D wave สูงกว่า S wave ได้ทีนี้เราจะแยกยังไงว่า S ที่น้อยกว่า D ในคนนี้เป็นสิ่งปกติเป็น Physiology ปกติหรือเป็น abnormal เราก็ดูพารามิเตอร์อื่นร่วมด้วยเช่นถ้าคนนี้ Mitral Valve Info โชว์ E over A และ Tissue Doppler โชว์ E palm over than A palm this is the normal okay if the patient has the grade 1 diastolic dysfunction okay you see decreased E velocity and increased A velocity and the tissue Doppler imaging might see the decreased E palm and increased A palm velocity. In the grade 1 pulmonic vein Doppler, it still be show S over D in the grade 1 and the AR velocity still be normal in the grade 1. When the patient has the grade 2 diastolic dysfunction, you see E is increased, E wave velocity is increased again, and A decreased. So you should differentiate the grade 2 pseudo-normalization from the normal. How can we differentiate it? ไหนแยกกันยังไงนะจะแยกเกรด2กับ normal ยังไงนะหนึ่งแยกเกรด2กับ normal ยังไงนะใช้อะไรนะ
Valsalva maneuver
Valsalva maneuver we use the Valsalva maneuver to differentiate between grade 2 and normal if the Valsalva maneuver shows significantly decrease the E wave velocity over 50% and E less than 8 this one is a grade 2 diastolic dysfunction. The other one you can look to for differentiation is to look on the T12 Doppler. You see, in the grade 2 diastolic dysfunction, the E palm and A palm are decreased both, but in the normal, you see, E palm is over than A palm. So if you see the normal tissue Doppler, if you see the patient who have the normal EA ratio E over A, and the tissue Doppler, you see the E palm over than A palm. This patient has the normal diastolic function, but the grade 2, you see E over A, but the tissue Doppler, you might see the decrease both E palm and A palm. And the pulmonary vein Doppler in the grade 2, you will start seeing the S decrease and D increase. So the S to D ratio is less than 1. This one, you start seeing that in the grade 2 diastolic dysfunction. Okay. So in the grade 1, the pulmonary vein Doppler is look normal. In the grade 2, you start seeing the S less than V, then S to D ratio less than 1. In the grade 3, you see the E over A, EA ratio is over 1.5, and the tissue Doppler, you see, is decreased both E palm and A palm, and the pulmonary vein Doppler, you see, decreased S wave and increased D wave, so the S to D ratio is less than 1. And this one, you might see the increased AR velocity. AR velocity is over than 35 centimeters per second. This might represent the high LA pressure and high LV filling pressure. And this one, in the MV inflow, in the grade 3 and grade 4, is called the restrictive physiology. You might see the short IVRT and short DT from the grade 3 and grade 4. But you can differentiate the grade 3 and grade 4 by use the Valsalva manual. If you perform the Valsalva manual and the E-wave velocity is significantly decreased, this patient is the reversible diastolic function. This is the grade T diastolic function. And the next one is the mitral rainfall propagation velocity. I will skip it because in the real practice we not often use it. Okay, the next one is the just briefly the talk about the T index. What's about the T index? T index is the time index of the time. The concept of the T index is the T index is the formula that consists of the IVCT plus the IVRT and divided all of this with the ET is the ejection time. T index is performed by the tissue of Doppler or the normal Doppler from the MV in the left side. We use the mitral valve. On the right side, we use the inflow from the tricuspid valve. I think you just remember this formula. T index is the IVCT plus IVRT divided with the ET. And how to measure it? You see this picture here. IVCT is start from the end of A arm velocity and before the initial of the S1. Yeah, this is the IVCT, and the IVRT is start from the end of the S to the initial of the E arm. This is the IVRT. It's the Volumetric Relaxation time. You add both of these and divided by ejection time. Ejection time is the time of the S-palm velocity. So the abnormal ratio is caused from the IVCT is increased and IVRT increased. So when the IVCT increase and IVRT increase in the abnormal heart condition, so the ratio would be increased. This is from the normal Doppler. Okay, the normal value is about 2.42. If the condition if the patient who have the systolic dysfunction, the patient may have prolonged the IVCT and the short ET. So the ratio of this one is increased. But if the patient who have the both systolic and diastolic dysfunction, it prolong both IVCT and IVRT and short ET. So this ratio is also increased. Okay. that ที่พูดมาทั้งหมดก็คือเวลาวิธีการในการ evaluate diastolic function start from the 2D M mode to look on the B bump. The Doppler is start from the MV inflow imaging and the tissue Doppler imaging and harmonic rain Doppler and the tail index. Index, you just know briefly the concept of the formula of the IVCT plus IVRT and divided by the ET. When the patient has systolic dysfunction, IVCT is prolonged and short ET. When the patient has diastolic dysfunction, it's prolonged both IVCT, IVRT, and short ET. Okay. From the last updated guideline, we use the 4 variable parameter to grading diastolic function. The first one, we use the septal EPAM and lateral EPAM. The septal EPAM less than 7 centimeters per second and lateral EPAM less than 10. This is the abnormal. And average E to E palm is mean the average from the medial E to E palm ratio and lateral E to E palm ratio. Okay, we get the E from the MV inflow. We get E palm from the tissue Doppler imaging. So we get the medial E to E palm and lateral E to E palm. So you get the mean value of what is the average E to E palm. And then we measure the LA volume index from the apical 4 chamber and apical 2 chamber. The last step is to acquire the TR jet velocity. Okay. The abnormal number is the septal EPAM less than 7, lateral EPAM less than 10 centimeters per second, or average E to EPAM ratio is over 14, LA volume index over 34. Remind you again, is LA volume index abnormal number is start from 34 to 35 to 41 is the mildly increase. 42 to 48 and over 48 is the severely dilate. And the TR velocity, you get the TR jet and you use the CW Doppler to get the maximal velocity of the TR. If it over 4.8 meters per second, this is the abnormal. So we use these four variables and to classify the patient. Okay, if the patient has the 1 or 0 parameter positive, this is the normal diastolic function. But if the patient who have the 2 from 4 variable abnormal, this is the indeterminate. But if the patient have 3 or 4 variables abnormal, this group patient have absolutely diastolic dysfunction. And then we look on the detail in this one. When the MV inflow, this one E to โอเคเอาอย่างนี้ทุกวันนี้ standard ในการ evaluate diastolic function อย่างที่สอนมาทั้งหมดก็ให้มาดูแค่4ข้อที่เมื่อกี้ four variable ที่บอกหลังจากนั้นเนี่ยจะดูว่ามันผิดปกติยังไงให้มาเปิดตาม category อย่างนี้เอาอันนี้ต้องลองไปเปิดดูแล้วท่องเองมันคือที่มาของที่พูดมาทั้งหมดในวันนี้ถ้าจะให้ไม่งงอันนี้ในทางปฏิบัติจริงๆผมเองเอาจริงๆก็ไม่ค่อยได้ใช้มันมากก็หลักๆผมก็จะดู4พารามิเตอร์นี้เป็นหลักถ้าเมื่อไหร่ก็ตามที่มันเจอ3ใน4อันเนี้ยเราก็เจอ average E ต่อ E prime ratio ที่มันสูงเกิน14ก็บอกว่าคนนี้น่าจะมี diastolic dysfunction and elevated LV filling pressure ประมาณนี้ที่ควรจะรู้สรุปเวลาokay, summarize the report about the diastolic function. The first one, the diastolic function in this patient is normal or abnormal or indeterminate. Normal is the 0 or 1 parameter from the 4 variable is these are normal. Dysfunction is the 3 to 4 variables abnormal. Indeterminate is the 2 variables is the abnormal. And then LV filling pressure is normal or elevated or inconclusive. And the grading, when the patient has dysfunction, the grading is 1, 2, or 3, or 4. Grading of the diastolic dysfunction. Okay, in some special condition, I think just know about the atrial fibrillation because this is commonly seen in the practice. Okay, in the atrial fibrillation, you know when you evaluate all of this parameter in the atrial fibrillation from the MV inflow, this appear of the A wave because the AFib is loss of the atrial clip. So we should not see the A wave from the MV inflow. And also in the tissue Doppler imaging, the patient who have AFib is with loss of the A palm from the tissue Doppler, and also we should loss of the A reversal from the pulmonic vein Doppler. So when we evaluate the patient, the diastolic function in the atrial fibrillation, we use the first one, the peak TR velocity. If it over 2.8 meters per second, this one suggests the patient might have elevated airway pressure. The second one, we get the mitral DT, this one E, and take the measure the DT is the decelerating time. If it's less than 160 millisecond, this one you should suspect patient might have the elevated LV filling pressure. Or you use the IVRT. IVRT is the timing from the end of T wave to the initial of the E wave. This one is the IVRT. You know, the normal number is about the 70 to 90 millisecond. This is the normal. But if it's less than 65 millisecond, this one you should suspect abnormal or elevated LV filling pressure in the atrial fibrillation. Or we use the E to E palm ratio. This one is no longer used because the VP is a mitral propagation velocity. The guideline is not recommend use. Okay, so in the practice, we use the E palm ratio, E to E palm ratio over 11. It's different from the normal. It's different from the patient who not have the atrial fibrillation. That in general population, we use the average E to E palm ratio over 14 or medial E to E palm ratio over 15. But in the AFib, we use over 11. And we should we look on the DT less than 160 millisecond and IVRT less than 65 seconds, and also peak TR velocity over 2.8. We could not use only single parameters to specific about the diastolic dysfunction or elevated LV filling pressure in the atrial fibrillation. We have to use many parameters to look the overall parameter to conclude this patient has the elevated LV filling pressure or not. Okay. I think it's all set now. So we have to talk today. Okay, any question, please? เข้าใจไหมครับวันนี้มันอาจจะดูยากซับซ้อนหน่อยแล้วถ้ายิ่งไม่เคยทำเลยเนี่ยมันเข้าใจยากอยู่แต่ว่าเบื้องต้นพยายามจะให้เข้าใจพารามิเตอร์ต่างๆ Physiology มันเป็นยังไงแล้วพอเวลาได้ไป touch the patient ได้ perform the echo จริงๆแล้วได้ทำ วอลุ่มเคสเยอะขึ้นเนี่ยมันก็จะทำให้เราเข้าใจมากขึ้นนะมีคำถามอะไรไหมครับ หรือว่าเข้าฌานเข้าป่าไปเรียบร้อยแล้วครับ
ไม่มีคำถามค่ะ
เพราะว่าหิวข้าวกันแล้วงั้นพี่ถามน้องๆหน่อยคิดว่าวันนี้ที่สอนเนี่ยเก็ตได้สักกี่เปอร์เซ็นต์นะอันนี้ฟีดแบ็กได้เลยนะเต็มที่นะคือพี่เข้าใจเลยว่าเวลาสอนอย่างเงี้ยมันไม่เหมือนกับสอนออนไซต์มันทำให้เข้าใจลำบากขึ้นเวลาที่มันไม่มี participate กันเนี่ยมันยากที่จะเข้าใจว่าเด็กๆรู้เรื่องไหมให้ฟีดแบ็กได้เลยเต็มที่เลย
หนูคิดว่ามันจะต้องไปเรียนย้อนทวนอีกรอบนึงอะค่ะเปิดวิดีโอแล้วก็ทวนอีกรอบถึงจะเข้าใจมากขึ้นนะคะเพราะว่าตอนนี้เหมือนแบบพอ
มันเยอะ
มันใช่ค่ะคือมันค่อนข้างเยอะนิดนึงค่ะแบบว่ามันเข้าใจได้แค่ทีละนิดอะไรอย่างเงี้ยค่ะแล้ว
3 ชั่วโมงเนี่ยคิดว่ามันเยอะ
ทำความเข้าใจ
ไหม
เยอะค่ะ เยอะพอสมควรเลย
ถ้าอย่างนั้นน่ะต้องฟีดแบ็กที่หลักสูตรว่าจะทำยังไงให้มันซอยให้มันคือจริงๆข้อเสียคือในช่วงนี้มันเป็นโควิดไงคือจริงๆถ้าเป็นไปได้อยากให้เรียนทีละชั่วโมงแล้วก็ไปทำเอ็กโคไปทำปฏิบัติจริงไงมันจะทำให้เก็ตอะไรได้มากกว่าแล้วพอมาเรียนสเต็ปถัดไปเราก็ไปทำเรียนแล้วก็ไปทำเนี่ยมันจะทำให้เก็ตอะไรได้ง่ายมากขึ้นอะไรก็ตามที่เรียนแล้วเรียนแต่ learn only theory เนี่ย without practice I think it's very tough to understand all of this มีฟีดแบ็กอะไรอีกไหมครับบอกได้เลยหรือจะฟีดแบ็กกลับไปที่หลักสูตรก็ได้พี่พูดภาษาอังกฤษเข้าใจไหมเอ่ยหรือว่ามันฟังยากอันนี้บอกได้เลยนะเพราะเอาจริงพี่ก็ไม่ค่อยได้เลคเชอร์เป็นภาษาอังกฤษเท่าไหร่
เข้าใจค่ะ
หรือพี่พูดยืดไปมากไปไหม
หนูว่าเป็นเพราะเนื้อหามันเยอะมากกว่าค่ะมันเลยใช้เวลาค่อนข้างนานค่ะค่ะแล้วเหมือนแบบอาจารย์ต้องอธิบายแบบซ้ำๆหลายรอบใช่ไหมคะมันก็เลยอาจจะแบบใช้เวลาเยอะค่ะไม่น่าจะไม่เกี่ยวกับจังหวะการพูดค่ะค่ะ
ถ้าอย่าง MV Inflow เนี่ยเข้าใจบ้างไหม
หนูไม่มั่นใจค่ะว่าหนูแบบจะเข้าใจแบบได้มากขนาดนั้นไหมคะเพราะว่าจริงๆต้องถามเพื่อนที่เขาแบบว่าคล่องนิดนึงค่ะหนูไม่ค่อยคล่องเท่าไหร่เลยไม่ค่อยแน่ใจค่ะว่าจะอธิบายยังไงดีค่ะ
ไหนขอฟีดแบ็กจากคนอื่นบ้างสิครับ
ของหนูเข้าใจบ้างไม่เข้าใจบ้างรวมๆกันนะคะแต่คิดว่าถ้าไปอ่านอีกก็น่าจะเข้าใจขึ้นนะคะเพราะว่ามันเยอะอะค่ะ
มันเยอะใช่แล้วรีซอสที่จะไปอ่านจากไหน
ก็ถ้าของหนูก็ดูสไลด์เดิมนี่แหละค่ะแต่ว่าอาจจะดูให้ละเอียดขึ้นเหมือนบางทีหนูก็พอมันเยอะเกินเหมือนสมองหนูมันก็เบลอๆค่ะก็แบบ
คืออย่างนี้
นั่งสมาธิไปบ้าง
สไลด์เนี่ยมันเป็นแค่ดึงแต่เมนท็อปิกออกมาจริงๆถ้าตรงไหนที่ไม่เก็ตนะไปโหลดสไลด์ตามในนี้เนี่ยไปโหลด ASE ไกด์ไลน์แล้วไปอ่านตรงที่มันไม่เคลียร์ตามหัวข้อไม่ได้ต้องอ่านหมดนะ ไกด์ไลน์เนี่ยมัน100 กว่าหน้าไปย่อยเฉพาะพารากราฟที่ตรงส่วนที่ไม่เข้าใจจากไกด์ไลน์อันเนี้ยพอเอาแค่ไกด์ไลน์นี้ก็เอา2 อันเนี้ยมันเหมือนกันตัว text ตัว content เหมือนกันหมดทุกอย่างเพียงแต่ว่ามันเป็น2 ค่ายในค่ายหนึ่งมันเป็นของอเมริกันค่ายหนึ่งเป็นของยุโรปแต่มันออกมาล้อกันแค่นั้นเองไปโหลดอันใดอันหนึ่งอ่านได้หมดแล้วเวลาอ่านแนะนำว่าถ้าจะเอาไว้สำหรับ for examination แล้วก็ for ให้เรา getting เพื่อที่จะไปทำ echo ได้เนี่ยเอาแค่ MV inflow tissue Doppler แล้วก็ Harmonic Rainfall Doppler เนี่ยเบสิกพวกนี้เอาให้เข้าใจแล้วพอถึงเวลาไป practice จริงมันจะได้พอทำได้เดี๋ยวนะในคลาสเนี่ยส่วนใหญ่อันนี้คือปี 3ถูกไหม
ใช่ค่ะ ปี 3
หรองั้นพี่ถามน้องๆนิดนึงเดี๋ยวบ่ายโมงมีเรียนอะไรไหม
มีค่ะ
อ๋อโอเคงั้นถามตั้งคำถามเดียวเลยแยกย้ายละถามนิดนึงมีเขาตกลงมีแพลนที่จะให้จะเปิด Echo Lab เมื่อไหร่อ่ะ
เข้าไปทำแลบเหรอคะอาจารย์
ฮะ
ตอนธันวามีเข้าไปทำแลบที่มอค่ะ
โอเคก็พยายามต้องไปทำดูอ่ะฝึกกับเพื่อนจับทำแล้วจะได้เข้าใจแล้วมีใครในที่นี้แพลนจะเรียน Echo หรือว่าส่วนใหญ่จะเรียนปั๊มกันต่อ
หนูสนใจอยู่นะคะอาจารย์แต่ว่ายังไม่แน่ใจค่ะต้องรอดูต่อไปอยู่ค่ะเพราะว่าตอนนี้ยังเรียนวนไม่ครบเหมือนกันค่ะ
คือส่วนหนึ่งต้องยอมแล้วว่ามันเป็นเพราะว่าตอนนี้มันเป็นโควิดไงแล้วการเรียนออนไลน์มันไม่ดีเท่ากับออนไซต์แล้วก็อย่างที่บอกถ้ามันไม่ได้ practice มันจะไม่ค่อยโอเคมัน practice มันแล้วมันจะทำให้เห็นภาพชัดเจนขึ้นโอเคงั้นไม่กวนเวลาแล้วละเดี๋ยวไว้มีโอกาสค่อยเจอกันใหม่โอเคโชคดีทุกคนนะครับผม
ขอบคุณอาจารย์ด้วยค่ะ
ขอบคุณอาจารย์ค่ะ
ขอบคุณค่ะ
ครับผมสวัสดีครับโทษนะครับ
ค่ะอาจารย์
เดี๋ยวนะคิดว่าเด็กๆส่วนใหญ่รู้เรื่องไหมหรือว่ายังไง
น่าจะช่วงถ้าเป็น Echo เนี่ยค่ะคิดว่าเขาน่าจะยังไม่เก็ตเรื่องคอนเซ็ปต์เรื่องการใช้ practical skill ค่ะเรื่องการวางเลยทำให้เห็นภาพแบบได้ไม่เท่าเหมือนปีก่อนๆนะคะอาจารย์เพราะว่าปีนี้ยังนักศึกษายังไม่ได้จับเครื่องมือกันเท่าไหร่เลยอะค่ะ
แล้วตกลงแผนว่าจะให้เริ่มเมื่อไหร่
เหมือนตอนนี้เบื้องต้นนะคะทางมหาลัยก็เริ่มให้ปี4อะค่ะคือก่อนหน้านี้ปี4เข้ามา practice เป็นเทรนก่อนไปฝึกงานนะคะส่วนปี3ก็คือจัดตารางไว้ว่าช่วงต้นธันวาเนี้ยค่ะจะเริ่มให้เข้ามาทั้งวาง Echo แล้วก็ลองมาต่อพวกปั๊มอะค่ะอาจารย์
อ๋อโอเคแล้วขวัญกับบุ๋มยังได้ไปช่วยไหมครับ
ตอนนี้มีอาจารย์กิ่งการค่ะอาจารย์พี่อุ้มค่ะ
โอเคได้ครับไม่เป็นไรแล้วแพนเลคเชอร์รอบหน้าเมื่อไหร่ครับ
แพนเลคเชอร์รอบหน้าถ้าเป็น Echo อะค่ะอาจารย์น่าจะเป็นถ้าเกี่ยวกับเราน่าจะเป็นของปีหน้าเลยค่ะอาจารย์สะดวกสอนอยากสอนสักหัวข้อไหมคะอาจารย์ตอนนี้ก็กำลังทำหาถ้าเป็น Echo ค่ะจะเป็นช่วงต้นปีหน้าค่ะอาจารย์แต่ว่ายังจะไม่แน่ใจว่าเป็นเดือนไหนค่ะต้องรอตารางออกมาอีกทีนึงค่ะ
ถ้าผมจำไม่ผิดผมเคยสอนเรื่อง Valve stenosis มั้งแล้วก็อะไรอีกเรื่องไม่รู้ผมจำไม่ได้แล้วเหมือนกัน แต่ก็ไม่เป็นไรถ้าจะให้ช่วยสอนอะไรบอกหรือว่าจะให้หาคนช่วยสอนเพิ่มบอก
ได้ค่ะอาจารย์
โอ
ก็
เค
ถ้าเป็นหัวข้อเว้าน่าจะเป็นถ้าอาจารย์เคยสอนเป็นเรื่อง stenosis ก็อาจจะเป็นหัวข้อเดิมค่ะอาจารย์
โอเคได้ครับ อย่างอื่นมีคอมเมนต์อะไรอีกไหมถ้ามีบอกได้เลย
ได้ค่ะอาจารย์คือมันก็อาจจะยากที่นักศึกษาอันนี้เป็นเรื่องใหม่อะค่ะนักศึกษาก็เลยอาจจะเหมือนแบบค่อนข้างงงๆแต่คิดว่าถ้าเหมือนได้เรียนออนไซต์มันก็อาจจะดีขึ้นนะคะมันได้เห็นทั้งเหมือนแบบexpression บนหน้านักศึกษาค่ะว่าเขาเข้าใจจริงไหมหรือเขาแค่เหมือนยังไม่เก็ตจริงๆแต่เขาตอบว่าเข้าใจอย่างเงี้ยค่ะมันก็เลยเป็นตัวที่ทำให้มันยากอย่างหนึ่งด้วย
ใช่โอเคได้ครับงานก็ตามนี้
อาจารย์คะแล้วก็เรื่องเลขบัญชีอะค่ะ เป็นเลขบัญชีเดิมไหมคะเพราะว่าทางการเงินเขาน่าจะมีข้อมูลเก็บไว้อะค่ะ
เลขบัญชีเดิมเลยก็ได้ครับ
ได้ค่ะ
ไม่
อา
ต้
จา
อง
รย์
ถามนะตกลงมันเสียภาษีไหมผมไม่เคยได้ใบภาษีมาเลย
น่าจะไม่แน่ใจเรื่องภาษีเหมือนกันนะคะ แต่คิดว่าทางวิทยาลัยเขาน่าจะจัดการให้แล้วนะคะ
โอเคได้ครับงานตามนั้นเลย
ได้ค่ะอาจารย์
ขอบคุณครับถ้ามีอะไร
ขอบคุณค่ะ ค่ะ ได้ค่ะ
ได้ครับโอเค
ค่ะ สวัสดีค่ะ